Hello, and welcome to the Clinical Care Options Infectious Disease Podcast. I'm your host, Sarah Anderson. In part 2 of a 2-part series, this episode features content regarding rational use and combinations of new and emerging treatment options for hepatitis delta. During this podcast, Dr. Heiner Wedemeyer, professor and chairman in the Department of Gastroenterology, Hepatology, and Endocrinology at Hannover Medical School in Hannover, Germany, and Dr. Cihan Yurdaydin, professor and chief in the Department of Gastroenterology and Hepatology at Koç University Medical School in Istanbul, Turkey, discuss new and emerging treatment options for hepatitis delta, including when they should be used and when they might be combined. For more information about Dr. Wedemeyer and Dr. Yurdaydin, and for a link to the full online educational program, please visit the link in the show notes for this episode. Now, let's get started and hear what Dr. Wedemeyer and Dr. Yurdaydin have to say about new and emerging treatment options for hepatitis delta.
Now, question to you about interferon. Do you still use interferon for delta hepatitis?
The short answer is yes. I still use, and your question relates, obviously, I have the privilege in Germany that since 18 months, I can prescribe bulevirtide. So I have an approved alternative treatment, which I can use. But interferon, and the two of us have been involved in many trials exploring interferon. And why do I use interferon? First of all, interferon has been shown to be beneficial for a substantial proportion of patients. It's not 100%, it's also not 60%, but it's 20, 30, 40%, depending on the population. We also both have shown that if you treat patients with interferon, that this is, first of all, a finite treatment, so it's not forever, and that if these patients benefit on treatment, in terms of biological markers, ALT, and so on, they have a long-term benefit. They have an improved clinical long-term outcome, and this association between successful interferon treatment and better long-term outcome. You showed this with your data from Turkey. This has been shown already 15 years ago with data from Italy. This has currently been shown with data from the King's College, from France, from Sweden. We showed it from Germany. There's data from Spain. And I think all go in the same direction, that successful interferon treatment is associated with an improved clinical long-term outcome. And this is, I think, pretty strong data.
And also the possibility of surface antigen clearance as well.
Absolutely. But let's say this was some disappointment in all these trials. You have the possibility of S loss, but the proportion of patients is small. So let's say we are not talking about 30%, not 20%. We're talking about S loss in the short term only in 5 to 6 to 7%,
yes,
maybe a little later. Yeah.
Long term, the story changes. Okay, my second question to you about interferon treatment. You have treated the patient for 1 year. You usually treat the patient for 1 year, right? Because you mentioned finite treatment. After 1 year, the patient is still HDV-RNA positive, but his or hers ALT has been normalized. HDV-RNA is more than 2 log slower than at baseline. What do you do?
You mean S antigen is 2 log lower?
No, HDV-RNA.
RNA, yeah. So this is now really for the experts in the field, how to tailor and to personalize HDV interferon treatment. So in general, you're right, I treat my patients for 1 year. And I continue treatment only if quantitative S levels have significantly declined. Because that
significant decline.
At least 1 log, if they're still on the declining phase, because then my goal would be to induce in the long term S clearance, really. So I really need to see something. Otherwise, I stop because interferon may have side effects. And if I continue in individual patients, it really depends on also tolerability of, I don't torture them. This is obviously always the most important point. But I do not continue, let's say, even in borderline patients at this stage, because I have now an alternative. I have bulevirtide, which is a different mode of action. If I would not have bulevirtide as an alternative available, I maybe, let's say, more aggressive in playing, tailoring treatment, maybe treatment pause, restart treatment, discussing side effects with patients, as we did 3, 4, 5 years ago, where we really were fighting for each individual patients. But now I have an alternative. So if interferon does not work, if interferon has severe side effects, if I have borderline responses by whatever measures, then I consider an approved alternative treatment.
I still think your criteria is still quite strict. First of all, I totally agree that if you have the possibility and you start interferon, please do it with some weapons. And these are HDV RNA quantitative surface antigen levels the least. I have to say, even quantitative surface antigen levels in Turkey, for example, we can do it only in a private lab. University hospitals do not have quantitative surface antigen levels available. But it's not too expensive, and this is something a patient should consider, and the physician needs to consider definitely. If the patient is, I would check on treatment at month 6. And if the patient has a decrease of quantitative surface antigen levels by not 1 log, but just by simply 0.1 log, as you know from the neuro study from Italy, that should be motivation to continue treatment. And if the patient at the end of treatment at 1 year has also a 2-log decrease in HDV RNA, that should be fine.
And for those of you listening to our talk here, you may check papers published by Cihan Yurdaydin on this issue. For example, a very nice paper published in CGH in 2015 already on treatment markers and long-term responses. So this is something which there is data, but I think in future we will see hopefully more data. But Cihan, let's now move on to the new treatments. I think that's important. And can you, obviously, we have different groups or ideas how to treat patients. We have an entry inhibitor called bulevirtide, which is this peptide blocking entry of HBs antigen particles into an hepatocyte. We have the idea of so-called prenylation inhibition, and you may explain in a short what this is. We have other ideas. Interferon lambda is an alternative interferon. We have also, let's say, ideas which are less advanced in clinical development, but we have seen data. Nucleic acid polymers, for example, in clinical trials.gov, we can even find studies on using siRNAs against hepatitis B. That studies are ongoing there. And there are preclinical ideas using different substances to interfere with the hepatitis D life cycle. So overall, I think this is fantastic news for patients because there's a lot of things ongoing. There's hope, but the question is obviously for us now, in some countries, bulevirtide is available. And for us, it's now the question how to use it, but also thinking what else is in the pipeline. So what are your thoughts? Are, let's say, entry inhibitors the solution for everything? What are the, let's say, from your perspective, the opportunities, but also challenges?
Well, I mean, first of all, I totally agree. It's very good that we have now one new drug available in the market, at least in some countries. And hopefully there will be other drug or drugs to follow. And we have to be ready in an optimal way, treat the patients with these new weapons, so to say. And I think, as you know, we have published a paper with an expert panel where we suggest that a 2-log decrease at end of treatment, more than 2-log decrease at end of treatment is a mark of initial treatment efficacy. I think the wording initial treatment efficacy is very important because it means that either end of treatment is already end of treatment and it means final treatment, and we have to see if the efficacy continues in a good way, or if we have to do something to continue with good efficacy. And that could be continuous treatment, and this is something with bulevirtide monotherapy with continued treatment. We don't know how long we need to continue, but we have to continue. And maybe there would be, for new medications, two ways of continuation of treatment. One would be continuous continuation, and another way could be intermittent continuation of treatment. These are scenarios which we try to defend the initial treatment efficacy, that it continues like that.
We talked about bulevirtide as an option, and you're right. So the question is, what the future use of bulevirtide will be either maintenance treatment, as you mentioned. The second question is, can we stop treatment in a substantial monotherapy in a substantial number of patients? This will be answered by the ongoing 301 trial, where 2 versus 3 years of treatment is currently being explored. We will have the data in 1 or 2 years available. And the third option, and that would be my question to you, is you asked me about interferon. I'm asking you now about combination of interferon with bulevirtide.
Yes, that's a very attractive option, because the combination with interferon is an option for non-advanced liver disease patients due to delta hepatitis, because the studies have shown that you can have quantitative surface antigen level decreases. And talking about decrease, the decrease is not 0.1 log, but 1 log or more, which is very good news, actually. In that sense, combination of bulevirtide with regulated interferon could be a serious final treatment option. Now, it would be very interesting, actually, to see 2 new compounds used together. I don't know if that's going to happen, but it would be very interesting to see that as well.
Yeah, but maybe you can talk about this. You just published in December in Hepatology a very nice paper on lonafarnib, so which is a prenylation inhibitor, and this is a different idea, and you explored their different, let's say, dose regimens, and a phase 3 trial is ongoing with this respect. So can you briefly explain what is lonafarnib? And
lonafarnib is a prenylation inhibitor, or better to say, farnesyl transferase inhibitor, which is important in the context that you need prenylation or farnesylation for virion morphogenesis to be completed. So the surface antigen to cover the virion nucleoprotein complex of delta virus with the surface antigen you need to make the tissue lipophilic, and the prenylation enzyme, the enzyme leading to prenylation, contributes to this. So it finishes virion morphogenesis and helps to inhibit propagation, infecting other hepatocytes, and therefore decreases infection. So that's the whole issue about farnesyl transferase inhibition. Remember, with new medication, we don't use anything like HDV RNA replication inhibition, because HDV RNA polymerase is under the control of the host, and to inhibit HDV RNA is possible, but is dangerous, because we are going to harm the host as well.
I think that's important for the guys maybe not that much in the field. So HDV is a defective virion which uses host enzymes for replication, so a host polymerase, and it does not encode for an own polymerase which you could target with a direct acting antiviral, which Cihan mentioned. I think that's very important, and therefore to have, let's say, different ideas to interfere with replication is important. But Cihan, regarding lonafarnib, you showed that it has antiviral efficacy. You also showed that there are options in terms of boosting drug levels with ritonavir. You also showed that you can combine it with interferon. Now, from my perspective, we have bulevirtide, we have an entry inhibitor, which is really safe. So there is the patient tolerated very well, but it's once daily injection. It's not an oral drug, and it works in many but not all patients. There are some patients who may show only minor decline, and we don't know treatment duration. So when you look in the future, and if you could now design, let's say, your wish trial, if the companies would provide you with a drug, would you combine bulevirtide with lonafarnib?
Yes, I would do that. I mean, the other thing is that, first of all, you mentioned bulevirtide. Lonafarnib is an oral medication. Mm-hmm. That's an advantage of lonafarnib. but it has some GI side effects, which we try to overcome by boosting lonafarnib's intrahepatic concentration with ritonavir and decreasing concentrations in the gut, thereby decreasing the GI side effects. So that's one thing. The other thing is combining with interferon has probably an additional or synergistic efficacy, but this is also seen with bulevirtide. But to have this synergistic effect with bulevirtide, you have to inject people with 2 injections a day, or at least 2 injections together. I mean, one once a week, but the other every day. Now, with bulevirtide, lonafarnib combination, it would be 2 new drugs, and we have no idea what the outcome is going to be. It has to be tested. I mean, remember, when we had interferon for hepatitis C, it didn't make sense to combine it with ribavirin, and then came the spectacular results. The same could happen with lonafarnib and bulevirtide as well. Why not? Why not?
Cihan is reminding me to a very nice story. So we had hepatitis C treatment with interferon alone, very low efficacy and side effect prone. We had ribavirin alone, who did not cure a single patient as a monotherapy, but the combination was the winner. And here we have to see what's going on. So Cihan, to sum up here, I really enjoyed this talk. So first of all, I think we can state that Delta is still a relevant and not infrequent disease. The challenge is that it's affecting in most Western and European countries, but also North America, immigrant populations. And we have really to consider these language issues, cultural background, social stigma, which is special for Delta, which we have to deal with. Delta is a severe disease. It can really progress to liver cirrhosis more frequent. And we should not forget liver cancer, which is something we should not forget. The good news is we have very good diagnostic tools and reliable diagnostic tools, anti-HDV and HDV RNA. They just have to be used. And we have treatment options now. So if this is severe and if it can cause outcomes, we have treatment options. We still can use interferon, and Cihan, I think the two of us really contributed to this field to study interferon in Delta, and we have a lot of knowledge which patients are responding, which patients have less chances to respond. And finally, we have new treatments. So we have bulevirtide as an approved regimen, which is really a chance for many patients, but which still has, let's say, we have not answered all questions in terms of treatment duration, of optimal dosing, and of possible combinations with interferon. But beyond bulevirtide, there are also alternatives, lonafarnib most advanced, but also nucleic acid polymers, but also other ideas like interferon lambda. We didn't talk about lambda. We're also phase 3 trial is ongoing, and lambda has been used in hepatitis B, in hepatitis C, and was so important that is finally also now studied in Delta. And it's on us in the future to further develop this field and to combine lambda maybe with bulevirtide, or to combine lonafarnib with lambda as has been studied already at the NIH. So I think there are perspectives for patients. There's hope for patients, and I think this is, to me, the most important point. A lot of ongoing that in the end we can hopefully help our patients. Cihan, anything else to add?
I agree that for patients, it is a period of waiting for many patients because they hear about the news about new drugs, but for many, the new drugs are not available yet. And it is 1 or 2 years until the story will be better in terms of availability of new drugs, I hope. And in terms of lonafarnib, I want to add one thing, that in some patients, after a short course of lonafarnib, there is the possibility of a beneficial flare, which may be considered in non-cirrhotic chronic hepatitis delta patients as well as a treatment option.
We could talk forever, but I think the statement that immune control of Delta is possible, I think that's very important. So it's not like in HIV, where in the end antiviral treatments have to continue and you cannot stop, and then there is no long-term control in the end possible. We have immune control of Delta. There are patients who may have, let's say, immune flares. There are patients who spontaneously clear HDV infection. This is possible. And I think we now have to really understand in terms of research, why is this the case? Which are the determinants of immune control? Which are the determinants of treatment response? So we need also a lot of research in Delta, not only in terms of clinical studies, but simply understanding mechanisms, why some patients progress, why some patients control the virus, and why some patients respond to treatment, while in all three scenarios, others unfortunately do not. So more research to come.
Yes. And with this dual action of lonafarnib, the combination of bulevirtide with lonafarnib is even more attractive than it looks like.
So hopefully you guys learned something about HDV infection. Thank you, Cihan. It was a great talk.
Thank you very much to Dr. Wedemeyer and Dr. Yurdaydin, and thank you to our listeners for joining in. As a reminder, to view the full Don't Delay with Delta program on the Clinical Care Options website, click on the link in the show notes for this episode. And please be sure to check back regularly for more episodes on important infectious disease topics. Thank you.